Hello everyone and welcome to today's webinar, Breast Shield Sizing Translating the Evidence with Dr. Danielle Prime. Before we get started, I would like to go over a few items so you know how to participate in today's event. You've joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, select phone call in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. There are handouts for the webinar. Please be sure to download these before the end of the live event. We previously communicated that today's webinar would be eligible for continuing education, but have a change to note. Medela webinars are designed to help healthcare providers enable their clinical practice. This webinar will connect the science to our portfolio of breast shield solutions. No CEUs will be offered for today's webinar. Today's webinar is being recorded. All of our webinars are made available through Medela University. I would now like to introduce Dr. Danielle Prime. Danielle is a member of the medical research team at Medela AG, Switzerland. One of her major roles is to keep abreast of the latest research into human milk and lactation and endeavor to communicate this knowledge both internally within Medela and externally, medical and research community. Danielle completed her PhD in biochemistry in 2010 at the University of Western Australia with Professor Peter Hartman and the Human Lactation Research Group. The focus of her research has been centered on understanding more about the basic physiology of human lactation to provide clinicians and mothers evidence-based knowledge. Dr. Prime?
Thank you very much. Thanks to everyone on the call. I'm really excited to be doing this presentation and to bring to you a nice overview of the evidence of where shield sizing is currently sitting. It's a topic very near and dear to my heart, and I'm really excited to be able to share the presentation with you. So, full disclosure, on my next slide, as I click through, there it goes. I am currently an employer of Medela AG, as the intro stated. And what I want to walk through with you today is, firstly, a little bit of a recent history about the breast shield. And so recent meaning the last 20 years, which is really the amount of time I've been working on the topic as well. Then we'll lay the foundations with the anatomy. I want to walk you through all the different anatomical aspects that we need to consider when we talk about shield sizing. Then we'll talk about sizing from two key lenses, one being performance and the other one being safety. Then we'll cover the principles of breast shield sizing and more of a step-by-step process of how to go about it. And then I'll conclude with some additional and further considerations, because any of you working in this topic are aware that this is not a very simple process to undertake. So let's look firstly at the recent history. So for me, the shield topic started way back in around 2006 when I started my PhD. And I have to say, back then, the entire globe, when it came to breast shields, was very much on a bigger is better mentality. So in the last 20 years, we've done a big flip, which is great because science is an evolution, right? There was a tendency for bigger and bigger shields to be requested from the lactation community. We had tons of lactation experts sitting down saying we need bigger shields to be provided with the pump, to the point where even a 40mm shield was provided made out of glass and glass blown by hand. And then we saw data coming from hospitals saying up to 78% of mums were needing to switch to larger shields in the first days in hospital. This is likely linked to edema, and I'll cover that a little bit later as well. And edema protocols have really reduced this in recent years. And then as part of my PhD, I had the lovely Professor Diane Spatz come down, and we worked together during her sabbatical. And we conducted what was at the time the first comparison study of shields and sizes. We selected the 24, 27, and 30 size shields to test because they were the most commonly used shields in the US at the time, which is where Diane was coming from, but of course also across Australia and abroad. And the focus of the study was about these anatomical insights. So I'll bring them forward in this presentation because we did learn a lot during that, even if we were using these very large sizes for all mums. So then in around 2014, being from Perth, and I'm in Perth right now, so please forgive me, it is 11 p.m. I'm going to do my best, it's very late, but when I joined Medela in Switzerland, I would say, perhaps slightly frustrated because there were all these sizes being offered by pump manufacturers, but there were very little fitting guidelines available and very little guidelines that were evidence-based. And so in 2014, we really saw two key things. Number one was that shields at the time were labelled with a SML/XL sizing regime. And it was really clear when we interviewed mums and HCPs that this was being interpreted as needing to match their breast size rather than their nipple size. And so that could explain why some of these larger sizes were in fashion, right? So we've got a mum with a large breast, I need a large breast shield. And that's certainly not how fitting should work. It's really the nipple size rather than the breast size that should be taken into account. And so back in 2014, this first two-step fitting guideline was created. We created it and we validated it in the US, actually. I know a lot of the attendees will be in the US for this call. We had mums tested, we had HCPs sitting there assessing the mums and whether they had used the fitting guide appropriately, and then we had them use their selected shield for a number of weeks to make sure that it had a safe basis. And it sat there, and I'll cover some of the different options available today, but it sat there since 2014 in that form. So given...
Doctor,
Yes?
forgive me, if I may ask, could you adjust your microphone down just ever so
Down?
slightly? Down, yep.
How's that? Is that better?
I believe that is, yep, let's try that.
Right.
Thank you.
Okay, so given that we were focused on the breast, then we started to dig into the breast part of the shield, which is the flange. And I'll show you some literature around the flange part of the shield because that's also essential for fitting. And in 2020, we ran a full randomized controlled trial to look at that parameter of the shield and saw that a more open or wider opening angle of the flange could very much increase milk output. And so at this point in 2020, there was now a bundle of clear literature that existed that showed that breast shield design and fit are important factors that can improve milk removal, comfort, and overall experience. So we were really on this journey, and now we find ourselves in 2024, and we see lots more endeavours popping up around shield sizing and a nice evolution of this journey. And the other part that I'll bring to you today as well is my side hobby, which is the collection of my nipple database. Because back when we did the fitting guidelines and we saw this SML/XL issue, we really started to wonder, well, what is the true anatomy of the breast? How is it that we do not have a source of nipple diameters of the general anatomy of the lactating breast available at our disposal in order to support evidence-based sizing and considering comfort, performance, safety, and complexity to really translate all of that through. And so I'll mention some of the results of the nipple database or how we've utilized the nipple database in this endeavor as well.
Doctor,
Okay.
I am so sorry to ask this again, but if you would adjust it just further down, it's picking up.
Too much?
Let's try that.
Okay, that's one down. How's that?
I think that's
All
going to
right.
be better. Thank you so much.
No worries, thanks for telling me. So let's look at the breast shield. So the breast shield has two key components which are linked to clinical outcomes. And those two key components that we can modify within a breast shield, right, are the tunnel, and that's the part that's going to fit to the nipple, and the flange, and that's the part that's going to fit to the breast. And so we know that the flange and modifying the flange is going to result in improved milk outcomes and comfort ratings. And what we saw is that increasing the opening angle was important, so to 105 degrees. So we know that that part of the shield is important. We know that that part of the shield needs to fit to the breast structure and anatomy, and we had 3D breast scans to inform that shape. And then on the other side of the equation, we have the tunnel. And when it comes to the tunnel, it's a very simple circle structure, right? So we just have smaller or larger diameters, and that's also been linked to to clinical outcomes. But if you think of the shield, there's really these two levers we can pull to improve performance and comfort for mum. We can alter the flange, so the shape and the angle of the flange, so it fits to the breast well, and we can alter the tunnel in terms of the diameter and how it fits to the nipple well. So in order to look at the unmodifiable factor, which is the anatomy, I'll now step through the anatomy of the lactating breast, because I think it's really important that we all have this common foundation of the anatomy and how it therefore fits, because this is the non-modifiable element in the equation. When you're working with your mums, you have all kinds of anatomy come to you. And what you'll see is that some things will work really well for some mums and some will not work so well for other mums. And I'm hoping by stepping you through this anatomical basis, you'll start to understand or help you build a little toolkit inside your mind that helps you to assess why some things are working for mums in certain ways and the intra and inter-individual variation. So most importantly, obviously we have the milk producing tissue shown in this image. Now this of course is that little bunch of grapes, so you can see them circling around. We know that they are both producing and storing milk. Those are in the alveoli, but let's take that layer away. If we take that away, then we reveal the really complex network of milk ducts. And those milk ducts store less than 4% of milk. So their whole job is to transport milk from those alveoli and out the nipple. And we really need to make sure that they can do that transportation job as freely and as unimpeded and unobstructed as possible. In order to show that in a little bit more detail, I'll show you this ultrasound video of a milk duct in action. So what we're going to see is this is the tissue of a lactating breast. The ultrasound probe is sitting on the outside of the breast. The nipple would be top right of screen. This here, this black line is the milk duct in itself. When at rest, it's only 2 to 3 millimeters, so they're really quite tiny. But when we get a milk ejection, and we'll see those alveoli squeeze on the other side, you'll see the response of that and the milk flow through there and the expansion of the nipple. So if I press play now, so we're not in a milk ejection yet, we're applying something at the other end, we're stimulating with fast sucking rhythms, or the baby's stimulating with a fast sucking rhythm, we trigger that milk ejection, and now we're starting to see this massive diameter increase. So these milk ducts will increase up to 68% during a milk ejection as that positive pressure pushes the milk through and towards the nipple. Where we're going to see jets of milk on the other end. And what's important to recognize is that these milk ducts live very close to the surface of the skin. They're really very superficial. And with an ultrasound probe, if you take a segment of the breast where you can see these very open milk ducts sitting here, if you simply compress that with just a mild to moderate compression with an ultrasound transducer, you can see that many of those milk ducts are completely obliterated. So compression is really something to avoid in general for mums, and the shield is a source of potential compression. Now there's this other mystery component in the anatomy, and I bring it forward because it was one of the key outcomes of what Professor Diane Spatz and I discovered during that first initial study. So this component, which is simply intraglandular fat, so this is fat that's distributed throughout the glandular tissue within the breast. This fat type is related to the total amount of tissue in the breast, so there is generally more of it if the breast is larger. But what really showed up is that when we were fitting with these really large sizes, the 27 and the 30, we saw an association that if the mums were to have mid to high levels of intraglandular fat, then they were actually performing okay with these large shields. So what we deduced is that intraglandular fat amount may reduce the constriction of the milk ducts during expression. And what I mean by that is that it kind of provides a bit of a buffer. So it allows milk to be removed more easily, and it means that those milk ducts are less susceptible to being compressed, and probably makes these mums, or the data indicated, less susceptible to a really incorrectly sized shield. So this is a really interesting kind of mystery component that I want to bring forward, because whenever we're dealing with biological data, we see these kind of outliers, or we see this bundle of mums that don't quite make sense. And I have a really strong inkling that the amount of intraglandular fat in the breast is one of those drivers that maybe means some mums don't conform to certain fitting rules or processes that work quite well for other mums. So it's really something to keep in mind, and we'll mention it again later. And I want to note that in the studies that were conducted, we didn't have a large proportion of high BMI mums. So, you know, we're still talking here about mums within a normal bell curve. And of course, if you have too much intraglandular fat, that relationship may shift. So we don't have data on that. Okay, so now let's dig into milk duct compression. So if we talk about the breast, now you can see here, here's a shield with a sharper angle that is clearly compressing the tissue. And what you see in your clinical practice, I'm sure, over the years, are these types of red circles. Things that we don't like to see. You can really see that mums are really pushing the shields quite hard into their breast. And this is simply something we want to avoid. And one way of avoiding it was to modify the flange angle. And so that's exactly what the study did that was published in 2020, where the opening angle was increased. And what we saw is that when we increased the opening angle of the flange to 105, we had immediately really positive comfort feedback from mothers. But when we presented that comfort feedback into NICUs and into facilities where, you know, in a NICU, milk is medicine, right? And what we really heard strong pushback was, okay, it's more comfortable, that's interesting, but I'm not interested until I see performance data. Because unless it's getting out equivalent or more milk, that comfort is secondary to me having milk for my premature infants. So we took that on board, and that's why we in fact conducted the randomized controlled trial on it to really assess performance, because we wanted to make sure that we didn't go backwards with offering this part or altering this part of the breast shield. And luckily, you know, overall the results were great. We saw faster first milk ejection, likely because the nipple is a bit further in at the start, and so it allows a quicker engagement of the tissue. We saw an increase in milk output and efficiency. So at every time point, that yellow bar is higher, and that was 11.8% more milk at the end. We saw an increase in breast drainage, so an overall 4% increase in PAMA. We saw statistically higher comfort ratings. So that was great. And then we had the performance data to back up that this was an appropriate shift and it could make a real impact to mums. But now let's zoom into the nipple. So we've talked about the breast now, the anatomy, and those milk ducts that are sitting in the breast are, as I mentioned, around 2 to 3 millimeters in diameter. Now the nipple that's dealing with the tunnel, it's a little bit of a different beast, right? So we have a few nice studies. This one's a really nice one. It's actually cross sections of tissue all laid up to kind of reconstruct what a nipple would look like. And what is really clear is that the ducts narrow at the tip of the nipple. They widen in the middle a little bit, but what's interesting is look how tiny they are. So 0.06 millimeters at the tip of the nipple. So they're teensy tiny compared to 2 to 3 millimeters in the broader breast, right? Then there's a kind of a 10-fold increase in diameter when you get to here. So 0.7 millimeters, but still tiny. There's a narrowing of the milk ducts into a waist here as they arrive through the areola, which is really interesting. And Professor Donaghetti's will refer to this area here as being kind of like a kind of a bunched up concertina that needs elongation. And so, you know, we do really point out here that we need elongation and radial expansion of the nipple to ensure that those milk ducts are allowed to open up and freely remove milk. So that distension becomes really important. And the application of negative pressure at the other end is obviously key. So once we get that milk ejection, it's going to push the milk through. It's going to expand all those milk ducts in diameter. We need to elongate the nipple and radially expand the nipple to make sure that that expansion is allowed. And then we're basically applying a negative pressure from a baby or a pump on the other side. And that's allowing the system to work with the positive pressure of pushing the milk through the nipple, because the nipple is we like to talk it as kind of like the gatekeeper here, right? So depending on how tight those common orifices are and those narrow tips, it also probably depends then on how much that mum is likely to leak, for example, too. So the nipple anatomy is really, really interesting. And here is another view of the nipple under ultrasound. So you can see the nipple here. You can see those ducts really quite clearly here. You can barely see them in the nipple tip as they narrow down into that tiny amount. And here's the nipple areolar junction. And ultimately, we really want to make sure that these nipple ducts can expand, and that brings to the to allow the milk to flow freely. Okay, so now let's look at nipples then. So what do nipples actually look like? So the nipple database I was referring to at the beginning of the call has been, a hobby, a little life's work in the last couple of years. But basically what I've been able to collect is through 23 different sources of data and literature from 8 different countries, 1,136 nipples. And what's really interesting across this database is that the average is around 15 to 16 millimeters in diameter. That's the average nipple diameter that we see. However, like any biological system, check out the distribution, right? So we have mums all the way down here that are as small as 9 millimeters. These are all lactating mums. This is all post-birth. And then we also have on the other end mums in this large area. And I have here just greater than 25 millimeters in diameter, but the largest in the database is currently 30 millimeters in diameter. And when I cut the database by geography or by racial or ethnic category, I really don't see a difference in the histogram profile across the globe. And that kind of makes a lot of sense when you think about the fact that breastfeeding is something that is done globally and there has to be a nipple to baby fit. So there's something conserved about this. The fact that it always pops up at 15 to 16 millimeters on average, I think makes a lot of sense from an evolution perspective. Now on the far right there, that 30 millimeter nipple, just out of interest, was actually a Caucasian mother in the US. So we don't see, any of the myths that we hear a lot about certain ethnic categories having certain qualifiers. It's just not showing up. And obviously, as we mentioned at the beginning too, so large breasts do not necessarily have large nipples. So breast size does not equal breast shield size. That's really important, and so nipple diameter is key. And so we've been using this to help inform best practice around the shields. Then nipple expansion pops up. So we know that the nipple diameter increases post-pumping, and we know that this increase is around 2 to 3 millimeters in both the length of the nipple and the diameter of the nipple. And that's shown here in the histogram. You can see here in the middle here, the most mums in terms of frequency of expansion are sitting between that kind of 2 to 3 millimeter mark. But it varies again greatly between women. We see some women all the way out here that are expanding by around 8 millimeters, and some on this end over here that are expanding next to nothing or even getting a little bit smaller. So human anatomy is incredibly diverse. So there's just a real variation between women. But what I really like about the following data set is that I always try to lock on as a scientist into something that is somewhat consistent, right? And so I was able to crunch the data for these 3 different studies. And the first study in the table here is my own, the one that we did back with the 24, 27, and 30 shields. And what we saw is on average was a 2 millimeter increase. And here's your 95% confidence interval, so 1.4 to 2.5. There was a recent set of data that popped up in 2022. So I took that into this table here, and they saw an average of 2.3 millimeters. This was a US cohort. And again, a really similar 95% confidence interval. Then there was a recent study, again, just from last year, that used 21 and 24 shields, and they saw a 2.2 millimeter increase. Again, a really similar 95% CI. So what this shows is that there seems to be a really consistent anatomical change, even across different cohorts in different eras and different study locations. And the fact that these 3 studies are using 3 different shield sizing approaches, but they still see this constant of around 2 to 3 millimeter increase, tells me that it is a really consistent anatomical change. This study in the middle here, which actually had somewhat the highest increase, they were actually even going down to a size 15 millimeter tunnel. So something in here is really conserved. There's going to be around at least a 2 millimeter increase, 2 to 3 millimeters perhaps, but then there's this outlier group here where these mums need to be considered when they do even go above 3. And so this is what drives the recommendation that when you're sizing a mother, that you add space to the nipple diameter that you measure before the mother pumps, before the nipple has increased in diameter at all. This is the data that's driving the recommendation to add some space to make sure that if she expands, that she's not reaching the point of a too tight fit in the tunnel. So the sizing now, I want to talk about it from a perspective of performance and from safety. So I like this quote, breast shield design and fit are important factors that can improve milk removal, comfort, and overall experience for women. And I think everyone on the call can fully agree to that statement. So let's jump into the milk removal part now and talk a little bit about performance. And then I will show you some a little bit nasty statements from the safety perspective. So in general, when it comes to performance, there is a lot of literature around that shows that for a large proportion of mums, the standard sizes are objectively performing really well. And by objectively, I mean that we reference back to their infant. So we want mums, when they use a pump, to be removing a similar amount of milk as what their infant removes. If the pump can remove a similar proportion of the available milk as the infant does, then we have the theory that they can maintain milk production, right? Maintain milk supply. We want the mum or the pump to be removing a physiologically appropriate amount of milk from the breast, and we believe the infant is the best determinant of what is a physiologically appropriate amount of milk from the breast. So the research I'm going to show you now in this next animation are all mums between 1 and 6 months of lactation. They're all in established full milk supply. They're not experiencing any problems, okay? And what you can see is that in each of these studies, the percentage of available milk removed, which is a really objective measure, it requires the mum to do a full assessment for 24 hours with her infant. It requires a ton of pre and post breast milk samples to be collected to measure the fat content. There's a special algorithm that quantifies the entire breast structure and form in terms of the synthesis rate. And then from there, we're able to ascertain how well a pump performs in a 15-minute pump session. And so we have here a series of publications that have come out over the years, and you can see that on average, they're all hitting about the desired amount of what the infant would remove. And interestingly, in all of these studies, you see they're using the standard sizes. So a 24, 24, 24 only. All those mums were fitted to 24s. 24 and a 21 was the more recent data, and a 24 and a 21 also for that recent study. So the standard sizes are on average doing pretty well, and we commonly see in lactation-related research a rule of 2/3. We see around a third of mums that could always do a little bit better, about a third of mums that could maybe be optimized. And so that's on the next slide, the real opportunity for offering specialist support, because breast shield sizing is the ultimate opportunity to tailor and personalize fit, right? So breast shield sizing comes with the real benefit of being able to sit with the mum and personalize that interface, which is between the pump and the anatomy that we just discussed. So an incorrect fit can compromise milk flow due to compression of the milk ducts. I think we can all agree to that from the anatomy slides. And the diameter of the tunnel has been highlighted in the literature. These are quotes. So the diameter of the tunnel of the shield can affect milk output. The small size inhibited nipple distension, requiring a higher pressure to draw milk through the folded ducts. So again, kind of avoiding anything that's too tight. The main culprit for sore nipples during pumping is the use of an incorrectly sized breast shield. And re-evaluating fit is really important for problems related to pumping, such as sore nipples, recurrent plug ducts, or low milk supply. So these are all literature statements that really highlight the benefit and value of specialist support for mums who need to optimize milk output. On the former slide, you can see there's going to be a ton of mums who pretty much no matter what you put on them, they're very lucky, milk's going to flow, everything's going to be fine. But then for those mums that come to you that need your support, then I'm hoping that the rest of the talk is really able to support you in finding the best solution for these mums. So what does it mean to be too large or too small? So it's an interesting balance here. So I wanted to mention on the left side, the consequence of a tunnel that is too large. So a tunnel that is too large, what we don't like about it is that it encourages too much areola to be entering into the tunnel. And there's even a clinical target that exists. So less than 3 millimeters of areola entering the tunnel is the target. So less, so as little as possible. Because we know that if too much is entering, it causes discomfort, tissue compression. And we know that if the mum has an oversized breast shield, she has a reduced vacuum tolerance. When we were sizing those mums in those really large shields, and we weren't sizing them, we were just placing the same mum in all 3 shields and assessing how they performed. But we saw that same mum begin to choose lower and lower vacuums as she went up and as the wrong tissue was being drawn into the tunnel. And decreased milk expression, of course. But now if we look at the too small side here, so a too small tunnel restricts the nipple and causes friction. So now we're starting to see lots more discomfort and trauma events, and I'll mention that on the next slide. And if the tunnel is physically too small, now we're talking about impaired milk removal. If the nipple can't fit and it can't distend, then we're talking about no milk removal. And so on this side of the equation, I really want to bring in the caution that no matter what approach you do, we really do not want to have the situation where the mum finds herself in a fit that is truly too tight, because you can see here some of the adverse events that can occur. And going through the literature, there's a few nice papers now that actually have to specify reports that have been made to authority bodies, so for the FDA, for example, of adverse events related to pumps. So that I'll start with the first statement, which is more from a literature piece, but with an incorrect fit, nipple tissue will rub against the sides of the tunnel, causing friction, and this may lead to severe nipple excoriation. The second quote here I want to mention is that even with advice from lactation consultants, so this was directly from a paper from Leiter et al., it goes through all different pump injuries. Even with advice from lactation consultants, some users were injured. In one report, a consumer documented approval from her lactation consultant about the correct breast shield size, yet she still developed purple bruises, open sores, tenderness, and cracked nipples. And the last one here, a lactation consultant informed a patient that she needed to use a larger breast shield. Upon contacting the manufacturer, the mother was told a larger breast shield cannot be used with the breast pump she is using. The report explained that the mother's prolonged use of this improper breast shield resulted in the skin peeling off the tip of the nipple and ripping on the side. So perhaps it's again the scientist in me that loves to talk about the full range of normal and loves, I don't love to be, but am inherently more conservative. But these are the types of things that we see which make us really cautious about making sure if you're sizing a mum that you do lots of follow-up to make sure that none of these events begin to occur for her, because you can see that they can be really quite severe. Okay, so now we'll jump into the principles, knowing the performance and safety perspective. And so we'll now step through the fitting guide. So the fitting guide was created a long time ago, as we mentioned, but what's really important is that it's always contained 2 steps, and this is really important. So the measure component was always because when we look at a mum, there's many factors about the mum that we cannot ascertain, but we can measure the diameter of her nipple. So as a kind of a safe starting point, the diameter of her nipple is a good, safe starting point that can be measured from the outside. But the testing part, that second step, has always been equally as important, okay? So let's have a look at the measure side. So what we would say is to measure and select a size. So measure the nipple and then add 4 millimeters to the nipple diameter. And this has always been just simply considered to be a safe approach, something that the mum can do at home without supervision, without an expert like you in the room, something that is safe, because we know that the nipple diameter increases from 2 to 3 millimeters during pumping. And you saw those mums that increased by up to 3 or even 4. So we're really just trying to avoid the circumstance where the mum expands or swells and then hits the wall of that shield. So let's have a look here at a small video just to show the measurement technique, which is pretty simple, right? So when you're talking to mums, make sure that they're aware of the nipple and the areola. We found that most mums don't know what an areola is. They can't distinguish between nipple and areola. We can use a ruler, for example, to measure the diameter of the nipple. And then we state that choose a breast shield that is appropriately larger than this measurement. Okay, and then depending on what that measurement is, then we have obviously the sizes available to match to that rule. Now here I really want to mention that Generally, and I don't need the video to play anymore, so I'll pause it. Generally, guidelines across the board are going to recommend somewhere between 2 and 4 millimeters. That's the starting point because everyone is very focused again on this safe approach. So somewhere between there, for the general population, 4 millimeter is a really good safe starting point. But when you're working with mums side by side, so depending on the context, absolutely 2 to 4 millimeters seems, you're using your clinical judgment to determine whether or not a closer fit is appropriate. And then there is another approach that's been gaining popularity recently, which is really interesting, this closer to the nipple size fit that's been proposed. And awaiting some study results. I haven't seen anything. I did look this week to see if anything had popped up, but I haven't seen anything pop up yet. But I think this all depends on context, right? So if you have a mum and you're having a one-on-one session and you have a range of different shield sizes at your disposal and you're comfortable with your clinical judgment to go closer, the principles are the same. The principles are not to contact the side of the walls to the point of friction, not to allow areola to enter as much as possible. So I think this is all completely fine as long as you're using your clinical judgment and following up with the mum, because as you'll see, the nipple diameter and that edema and the swelling, that may change quite frequently, especially across the first 2 weeks after birth. So if we need to change size and you're really closely fitted, then the chances of some of those adverse events arising brings me some concern. Okay. So how to measure? So there's lots of different tools out there. Ideally, you're measuring before pumping or feeding simply to make sure that there's the least amount of nipple swelling present so that you're really ascertaining the true resting diameter of the nipple. If we measure the nipples, we use just simply the widest part, but consider some asymmetry. So the horizontal measure of the nipple tends to be slightly larger than the vertical measure of the nipple. And there can be differences between left and right breasts. And of course, nipple shapes are highly varied. The widest part may not be the base at all, right? You know, we have lots of different shaped nipples. We also have the kind of the doorknob, the bulbous nipple, which has kind of the stalk and the bulb. So the widest part is very much at the tip end compared to the waist. So again, all of the extremes and the bundle of biological variability make this always a little bit more complex. And to throw in there flat and inverted nipples, of course, as well, very interesting. There, of course, you probably do need to either palpate or stimulate the nipple somehow, or even apply some vacuum. So you might want to remeasure once things have settled down. But ultimately, whatever tool at your disposal is appropriate. In research, we tend to use digital calipers, so they actually have the live readout of the number on there because they're also easy to sanitize in between. We've also used lots of circles. We had nice cards with circles of every different millimeter. They were really great because they avoid having to deal with any of the asymmetry issues, because now you're dealing with a circle to get the closest fit to the nipple, which is really nice. But ultimately, measure again. If you're dealing with mums in those first 2 weeks, it can change over time. If you're dealing with mums more in established lactation, it seems to really stabilize by around 3 to 4 weeks. But we know across those first 2 weeks, it can still be really dynamic. So consider, hygiene, obviously, and which is the appropriate tool for your scenario, but I wouldn't say that there's a real preference for one over the other, because the next part, the test, is ultimately going to get you where you need to be. So if you've measured the nipple, then you've got an idea of what kind of tunnel is going to be an appropriate-ish fit for the mum. So then you start to test. And then what you'll see is that the size is now going to depend on the breast tissue, skin elasticity, and the edema. And of course, we have the simplistic images here, but it's never that simple, right? So too small, clearly here the nipple's not going in, it's too small. Here it's too large, there's too much areola going in, that's very clear. Correct fit, what we want is the nipple to be moving freely. There may be more or less space on either side of the nipple, but we want the nipple to be moving freely. And we can only assess this during pumping. And so this little video here just steps it through. But again, anything we show you is going to be really stylized, because that dynamic variability between mums is really hard to capture. But ultimately, the nipple should be moving freely. in the breast shield. If you're seeing here, now the nipple can't fully distend because it's getting restricted. And here, we're getting all of this area here that's rubbing over the tissue or too much creep into the tunnel. And that's what we want to avoid. So that's the fundamental principles. So of course, whatever you've measured at the start, whether you've started with a 4 or a 2 millimeter rule, the dynamics during pumping, that's the one that's going to get you as a lactation expert to the right size. Okay, so how to test? So it is best, given the dynamic scenario, it is best to observe at least 5 minutes of continual pumping to really see how that tissue progresses, just to make sure that nothing else pops up, no redness, no whiteness, that the tissue creep doesn't, really, we'll cover elasticity in a moment, but that tissue creep doesn't kind of get ahead of you. And in order to really assess it, we also need the mum to be in an expression vacuum pattern. And by that, I mean not in one of those stimulation patterns. The stimulation pattern is short, fast rhythms. It doesn't really fully engage the tissue. It just kind of flicks the tissue back and forth. And what we want is to be in a longer expression pattern. So we're really engaging the tissue with each cycle to observe it. And we want the mum to be at her maximum comfortable vacuum. And by that, I mean that that you need to assess with the mum. So you've got the shield on, she's pumping. Ideally now milk's already spraying because now you're in expression mode appropriately. She has milk flow because she has milk ejection. And now you're turning up the vacuum to find her maximum comfortable level. And what that means is turning it up all the way until she says, that's a little bit uncomfortable, and then stepping it back 1 or 2 levels until she says, okay, yeah, that's fine. That is her maximum comfortable level. And we know from very strong data that if you use your maximum comfortable vacuum, this is what MCV stands for, that's what's going to get you that same amount of milk as what the baby's able to get out of your breast. And if we reduce the vacuum even by 25%, you can see there's a reduction here. And if we reduce it even further, you see again and again these reductions. And so if we're using really weak vacuums, we're going to get really weak performances. So comfort is key. Talk to your mums. This is not a scenario of no pain, no gain. That is not the case here. It should not be painful. It should not be uncomfortable. More vacuum is not better, but the maximum comfortable level is what's going to get the most out of that pump session. And if you're trying multiple sizes, it's clearly will be different between sizes. And like I said, we saw that with those very large sizes. We saw those mums using quite weak vacuums in those large sizes. So when it's a really off fit, then we're going to start to see mums not able to tolerate such high. So if you switch sizes, then please reassess the vacuum to make sure we can optimize performance. Okay, so make sure the nipple is centered. I have to mention this because now with the advent of all these in-bra pumps, visibility can get really difficult. So this is going to be tricky for you if the mum comes in with one of these new in-bras and then you're trying to assess the nipple and visibility and centering it. It's going to get trickier and trickier. But do consider that, and if you're advising mums about it, and when they're at home, they should really try to figure out a way to check their nipple is centered, because we really do see lots of adverse events pop up because the nipple's not centered in there and it's rubbing. And I guess the more fitted the mum is, the more likely we need to be, really conscious of this. Observe each breast separately. They are not the same, so you might find a different size is more appropriate for each breast. And then I will mention the lubricant. So there is no common guideline out there as to which lubricant to use or how to use it, but it is a fairly strong consensus that they're very useful, especially when applied to the circumference of the nipple, and they're going to reduce that friction. But if you've got a mum who plans to use the lubricant, then it's really important that she does use it during your testing session, because it clearly is going to change the whole dynamics of the fit. So if she plans to use one, then make sure she brings it with her, and then you assess the fitting session with the lubricant. Okay, so testing step is essential. So the rule, that 4 millimeter rule, is purely a safe starting point, and then the testing is where you really get into the hands-on part with your mums, because there are things that you cannot tell before you start the pumping session. You cannot tell how much she's going to increase in diameter. She might be one of these mums, she might be one of these mums. You won't know until you start to pump. tissue elasticity, you really cannot tell at all what's going to happen there before pumping. Her sensation and comfort, maybe she has some sensitivities, and this intraglandular fat amount, right? So you might find a mum who just does fine no matter what you put on her, or you can't quite tweak her, and it may be because of the intraglandular fat. So don't forget about that mystery anatomical component, because I find him really interesting. Whenever you have a deviation from the rule, from what you're experiencing, well, this mum's behaving differently. What could be going on? It might be that. And not all mums are going to require expertly fitted shields, right? So of course, as I mentioned earlier, there's going to be a chunk of mums out there who are doing really well. They're getting out as much milk as their baby. They don't require expert advice and the time from you and your expertise. But of course, we need to consider mums that are pumping frequently, because the more we rely on the pump, the more this sizing topic becomes of critical importance. And whatever approach you're using and whatever solution you come up with for your mum, then make sure that you follow up, because repeated use is essential, especially in those first few weeks. Monitor comfort and monitor output, and make sure that that mum can contact you if the feeling starts to shift, and make sure maybe even that she has a backup shield, because we really don't want mums to leave and have a great week and then all of a sudden develop an adverse event. Okay. All right, so we've talked a little bit about mums in the general population. We've talked about mums that you might see that are experiencing issues or really want to optimize their pump sessions. But I have to also mention specifically hospital considerations, because this is another really fascinating topic that we need to keep in mind. So delivery of IV fluids to the mum during labour is definitely linked to postpartum breast changes, i.e. edema and swelling, particularly on the nipple. Now, this is really specific to hospital practice, and I know that over the last 5 years or so, there's been some nice new, curated edema protocols. So there was some years where there was a real challenge, I believe, of IV fluid overloading, and that seems to really have been reduced. So it's specific to your hospital practice. But if you are still in a facility where you see edema events in those first days, then be mindful that that can definitely impact shield sizing. So there are reports that indicate that mums with edema are going to do better with larger shields in the first days, but then they're going to follow with smaller shields once that edema subsides. And in 2010, which I mentioned back on my first slide, we saw a study from a hospital data set showing up to 78% of mums were switching to larger in those first days. But now the majority are using smaller, even within that same facility, because their IV fluid loading protocols are updated. So yeah, given the advent of certain populations and demographics and higher BMI mums and all these practices, do keep this in mind. And this is one of the reasons that hospital kits tend to have 2 sizes included. So there might be a temporary need for larger shields, and then you should see the need go back down to the smaller sizes once that edema has subsided. But it's really important to consider all of these different contexts. Elastic tissue. So here I don't have any real, evidentiary bullet points to give you on how to solve this, but we have to acknowledge it exists. So elastic tissue is tissue that's going to fill the shield tunnel, and almost to its entirety sometimes. There is no official data on what percentage of mothers have truly elastic tissue. I trolled my data set of mums that I've seen over the last years, and I could calculate circa a 4% rate of elasticity in the population. Perhaps you see more in your clinic because maybe they're coming forward experiencing issues and wanting optimization. But interestingly, that 4% rate, they thought they were fine. They didn't know that this was not normal. So here is before vacuum, right? Nothing looks out of the ordinary in terms of the tissue. You wouldn't expect that that would then just creep all the way down to the end of the tunnel. So that there is something that we need to watch out for. Now, how to solve that is much more complicated, because there's only anecdotal solutions, and you're just going to probably trial and error this because there's no clear position. Smaller sizing may restrict the tissue. That's one approach, to go smaller. But here is an example of a deep reaching nipple even with a 15 millimeter tunnel. So even that approach might have some limitations. It may not block that elastic tissue from doing what it wants to do. The other approach could be also to offer larger, just so you can physically accommodate the tissue and make sure the mum's comfortable when she's pumping. There are reports that perhaps different shapes and sizes of shields and designs may be beneficial, but there's no evidence. So try out what you can and see what's best to work for those mums. And I hope we get a lot more evidence on this population soon, because it's a really fascinating area that we really do lack information on. Okay, so when to use larger shields. So using a greater than 24 is clear when the nipple is larger, but this is only going to be for a small percentage of mums. But those larger shields may still be an option for elastic tissue, as I just mentioned, for postpartum edema, as I just mentioned, potentially for those mums that swell up, and potentially also for those mums with high degrees of intraglandular fat. They might do really well with those larger shields. So they're an interesting option for those use cases. And then I want to make a note here that if you remember back to my safety slide, so if the nipple cannot physically fit in a breast shield, the mother can't pump at all. So this is really the reason that these large shields exist, because even if they serve just a small percentage of mothers, that's a really important percentage of mothers that are very likely having breastfeeding difficulties too. If they have a truly large nipple, then infant latch is probably also challenging. So we really want to offer them an option to be able to get that milk out. And you saw the bell curve. There are mums on that end that are large. And it's also the reason why standard sizes are delivered with the pump in generally around 24 millimeters. And that's very simply to make sure that the vast majority of whoever picks up that pump or receives that pump can safely and immediately remove milk. Okay, so when to use smaller sizes. So for comfort and optimization, limiting the amount of areola and breast tissue entering the tunnel. We hunted into the nipple database and we really could see very, very clearly that around 36.4% of mums would be definitely suited to an 18 millimeter shield, smaller than the 21 that Medela currently offers. And so we are planning to offer that 18 millimeter shield this year, and we've already conducted some user research on that. We selected pump-dependent mums in the NICU because we really want to make sure it works for our most vulnerable population, those truly exclusive pumpers, with all of the complex etiology. So long-term data was collected with objective performance measures. And what we saw there, that data is pending, but what we saw is a 30% use rate of the 18 millimeter shield in that NICU population in those first 2 weeks. So definitely a need, and I'm really excited. I wanted this for a long time, so I'm really excited that this will be coming out soon. Okay, so in the last few minutes, I just have some watch outs and then some conclusions. So obviously, there's lots and lots and lots of different pumps on the market now. Lots of different shields popping up out there. It's all a bit crazy, really. So here's a few watch outs if you're trying to assess a pump or a shield that's coming in with your mums, right? So a few things that we really want to aim for is a tunnel length that's around 40 millimeters in length. We want to make sure that the angle is quite open, okay? So we know 105 is good. That would be a really good starting point. We want to make sure that the tunnel flange junction here is not sharp. So, rub your finger in there and make sure that it's nice and smooth surface as you jump over here. This is a really key area the tissue works with. If you're looking particularly maybe at the in-bra pumps, take a look down the tunnel and look inside, because that milk needs to be vented, right? Air needs to come in, milk needs to go down. And so these obstructions are being put into those tunnels. So rub your finger down and see like, oh, okay, is that a bit of an edge there? Could that cause something? There are absolutely adverse events happening with certain pumps where mums' nipples are having friction across these surfaces, and there's bleeding and not so nice things. Material is tricky, so there's always this push for soft, but everything, and Medela used to offer a soft shield as well, but all the reports on soft are that it's polarizing. So they seem to work really well for 50% of mums, and then they seem to not work very well for another 50% of mums. So again, if you have them at your disposal and you're interested in trying them on your mum, you might find a mum who really likes it, but they do tend to be quite polarizing, and the harder plastic flanges do tend to be more agreeable for the broader population. And there's all other features. So I also pulled this from that lighter publication. So the cushion that comes with the breast pump is too small, and it has cut my nipple, and over time has created a breast infection. So this was a complaint from a customer that was presented in that lighter presentation. So these are some watch outs. If you're going to assess the different shield options and products on the market, look out for those and make sure you're comfortable with all of those different parameters. And maybe those are some of the issues if to overcome if the user is not having a great time or wants to optimize her outcome more. Okay, so I'm coming to the last two slides now. I hope that I've explained the overview of breast shield sizing to you in a way that makes it a little bit clearer for you to translate into your practice, meaning that there are different approaches needed for different contexts. So here on the left, we know when you've got a mum purchasing a pump online, or perhaps just getting one for free from the insurance, or you have a bedside nurse who's super short on time, there's a pump indicator, I've just got to get that mum a pump set immediately. In these scenarios, what we need is a clear and safe starting point. And that's where that 4mm rule, or one of these increase in diameter rules, is really, really valuable, because it's going to be suitable for the majority, it's going to reduce complexity, and if they have performance success, as I showed you on that earlier slide with those publications, if we get that success for that mum, then those mums are not going to be coming over here to this specialist lactation support requirement. But for the mums that come across here and require that specialist lactation support, then you serve as the frontline worker. And it's up to you and your clinical judgment to dissect the work that I've shown you today. It really elevates your role in the skilled assessment, and feel free to do these tailored approaches when testing and fit closer to the nipple and try out what works, because of all those different factors that exist in the mum. You're going to see that personalization is going to be really important to get that mum across the line and having a happy experience with her pump. And follow up, I can't emphasize it enough. Make sure that you do follow up and that sticks. So in conclusion here, on the last slide, I think it's really clear that breast shield size is one of a suite of tools available to improve the mum's pumping journey. The right size is a balance of comfort, performance, and safety. That 4mm rule is a nice, just simple, clear, safe starting point, and it's suitable for the majority, reducing complexities. That's why it exists, but it is not the only guidance that one should take into account, because any additional support or any specialist lactation support, optimize and personalize and use all of the tips and tricks that I provided you, and consider the anatomy in all the ways I just described to find the right fit for the mum. There's no reason why you have to stay at the 4mm rule at all. So breast size doesn't equal shield size. We know that now. Nipple diameter and length will increase during pumping. That's why we do need some kind of clear, safe starting point, particularly for unsupervised use. Mums may need a different size per breast. Sizing may change, of course, across the course of lactation. Don't push those shields in too hard, because we could compress those milk ducts. And size will overall depend on breast tissue and skin elasticity. And you can only see this during pumping, so assess during a pump session. And the different sizing approaches out there, you may find it confusing that there are these different approaches, but they're simply varying according to context. So if you just consider your context and which of those shield sizing approaches is appropriate for you. Okay, and that's the end of the presentation. Thank you very much.
Thank you, Dr. Prime. And I believe we are at the end of our time just about. So we will gather the questions and ask Dr. Prime to answer those separately. Yep. And we'll send a follow-up with answers at a later time. Thank you again, Dr. Prime, and thank you everyone for attending today's webinar, Breast Shield Sizing, Translating the Evidence. There will be a survey at the end of the presentation, but we'd also like to let Angela Lang say a few words before we wrap up for the day. Angela?
Yeah, thanks, Wendy. Hi, I'm Angela Lang. I'm the Director of Medical Affairs and Clinical Education for Medela. And I just want to say we've had an amazing spirited discussion in the chat. And I want you all to know that there's many questions in the chat, and we will have all of them logged and make them available to you after the webinar. In all of our webinars, we do have the questions because we don't want to disrupt the speaker while we're doing them, and we always answer all of the questions. I want to assure you all that we are doing this webinar based on feedback and questions regarding the way we do sizing, and we are interested in your feedback and want to do webinars that actually engage lactation. So even though there's a lot of different ways to do sizing, we're presenting the way we're doing it. And then we'll also address all of your questions and concerns after. So thank you guys all so much for joining, and thank you, Dr. Prime, for sharing your knowledge with us today.
On behalf of Medela Education and our presenter, thank you again for joining us today, and have a great rest of your afternoon. Thank you.
Thanks.